So thank you very much for inviting me here. And yes, I have a fair amount of history, and I would say some present as well, connecting me to Israel. But the history it's referred to is actually, before I was born, my parents came here in the very early 50s to Mechon Weizmann, where my father led the group to build the Weizsack. And he just passed away 2 months ago. So some of you in the audience knew him. Quite a mensch. Okay, now you started me that way. And my more current history actually is my husband's Israeli, and I'll actually be here for a few months in the fall at the end of my sabbatical year. So I look forward to those of you interested in this topic following up. So you might have looked at the title for the conference and said, Networking, Cloud, and Beyond. What does that mean? Well, the title was actually Networking and Cloud, and then when I told them what the topic of my talk was, they couldn't really figure out how it actually fit, so they had to add this term. So that's how I understand it. So I don't know how you say in Hebrew now for something entirely different, but I want to tell you about what I've been doing with a lot of other people in this field of really leveraging mobile and the cloud to work on an aspect of personalized health. And it's a very opportunistic thing. It's really enabled by the fact that people have chosen to spend discretionary income, and walk around with these powerful instruments in their pockets. And those instruments have a number of interesting sensors on them, from GPS to imagers to accelerometers, and they're programmable. And then, most importantly, they're actually connected back to what we used to say the internet, and then we said the web, and now we say the cloud. And they're highly programmable through the whole notion of app stores that really Apple and iTunes and the App Store really brought to us. And most of what I'll talk about is by no means in any way rocket science. It's a lot of initially leveraging lots of things we already know how to do. It's a lot more opportunities to bring all that's been done in the context of mobile and cloud technologies to a kind of health innovation that we really need at this point in many parts of the world, where increasingly we're facing the personal, social, and economic burden of, in particular, chronic disease management. And so Scott and I go way back, and our talks and subject matter are entirely different, but you'll see some common themes because we sort of share some common heritage. So already here I have some variant on that hourglass, and I'll come back to that more at the end of the talk. But we also share this sort of notion of how important it is to have a killer app. And in some sense, in the context of leveraging mobile, we see, and yes, I mean it tongue-in-cheek, that really health and personal health is a killer app for leveraging mobile technologies. And this is an important problem because of need. These statistics are from the US, but there are similar statistics and definitely similar trends in developed nations, and increasingly, unfortunately, in developing countries, that in the US, and this is already a couple years old, and it's not getting better, more than half of Americans have one or more chronic disease, and that's not American patients, it's all Americans. And the age of onset is getting younger, and more you have comorbidity across chronic diseases, which makes, just as we know from troubleshooting anything, right? It's not, when you have only one thing going wrong, it's a lot easier to find and to address. But when you have multiple things going wrong, it's harder to find, it's harder to address, and there's that escalation of problems that comes as you address one thing, and it's interfered with by a second. And behavioral components are actually a big piece of what leads to premature mortality in the US. So at least a third of premature deaths can be associated with just basic behaviors, things like diet, lack of exercise, and smoking. And this isn't just a problem of the developed world. The World Economic Forum came out with an interesting report at the end of last year talking about that the economic burden over the next 20 years will be $30 trillion of non-communicable diseases. So not HIV, AIDS, and malaria, all those things which remain very important problems, but non-communicable chronic disease has a huge, and will have a huge economic burden, and mental health, an additional 16 trillion on top of this. So that's the problem, and the opportunity is that we have an opportunity to extend aspects of health beyond traditional clinical care. So outside of the enterprise, outside of what Eric Dishman from Intel likes to refer to as outside of mainframe healthcare, to where people, patients, consumers, whatever you like to call them, actually are. And so the real value then of mobile is making it easier for individuals, making it possible for individuals to actually understand what's happening, to manage their treatment, and to actually then produce evidence about what works and what doesn't. Because outside of a clinical setting, it's largely just up to self-report and intermittent observation. And so not only do we not have an affordable vehicle to help people with chronic disease management, we haven't really had an adequate vehicle by which to understand and produce the evidence base by which to treat people. And so it's really the case that we no longer lack the feasibility and affordability of tools to generate evidence around personalized health management. Now, when you hear about personalized medicine, the bulk of the attention, and it's all very important and very good, is really on the genomic side that will increasingly be able to understand better the processes of disease and the opportunities for treatment of disease by better understanding things from the genomic side. But even all the folks who work on that acknowledge very much there's also exposure and behavior, which has a big determinant as well in health outcomes. So mobile health, this kind of mobile health, which is focused on an individual using their mobile to capture data both automatically and sometimes through interaction around symptoms, side effects, outcome measures, and through most of the heavy lifting that actually happens in the cloud, coming into something that's actually actionable for the individual and for clinicians. So as you're thinking about this, focus on demographics that are actually digital natives to smartphones. So let's, for the moment, set aside.
Where's the microphone?
Sorry. Okay. Let's, for the moment, set aside. Don't think about text messaging. Think about a full capability of a smartphone. And in doing that, don't worry about the fact that the elderly are probably this generation's elderly are not adapted and big adopters of those technologies. So let's focus on sort of 15 to 55 with no interfering impairments. That's a big enough population, and as they age, this might have some applicability to elder care as well. The way to think about this and the way we approach it is really that there are three essential feedback loops that drive personalized health. And these feedback loops, as with most systems, if they are lack data at the right spatial resolution, temporal resolution, they don't function well. And so the opportunity here is about leveraging the mobile to bring data that is at the right level of detailed resolution to help individuals take care of themselves. So many medications are given, think about painkillers for back pain or migraines. It's take as needed. So what does as needed mean? This is basically an optimization problem. If you overtake, particularly things like opiate-based painkillers, you develop addiction. If you undertake, you're much more sedentary, and there are all sorts of health and functional effects that come from under-consuming. It's just an optimization problem. And it's a very individualized one in terms of what works for people. Think about the same thing, whether it's around antidepressants, anti-anxiety medication, as well as managing chronic diseases having to do with GI, IBD, Crohn's, all sort of colitis, neuromuscular things, MS. There's a lot of individual manifestation of symptoms and side effects and a lot of burden on the individual around self-management. And people with those conditions spend a lot of time figuring out how to optimize, what causes their flare-ups, how much medication to take to mitigate against side effects, and even with much more common things like high blood pressure medication. So high blood pressure medication for some people causes dizziness. one of the factors that leads, again, a US number, 60% of Americans prescribed high blood pressure medication stop taking it after 6 months. Now, high blood pressure medication is not something that you take it for a while and it fixes your high blood pressure, and then you're not supposed to take it anymore. High blood pressure is known as the silent killer. You don't feel the high blood pressure, but it has impact on your system. But you can feel the impact of the medication. Only natural that if you're having side effects and you don't feel the symptoms, you stop taking medication. So how do you make things that are less visible, actually visible to an individual, and then improve that feedback loop and that self-care? But health is not only about a self-care. This self-care is done in the context of clinical expertise. And the clinician is in that loop less frequently, titrating medication, adjusting treatment, adding medications. If you've ever known anyone who's gone in for treatment for depression, it's probably one of those prime examples where there are many places to start an individual in many different medications, mixtures of medications, and certainly many doses you can start somebody on. And of course, you start at a low dose, right? And the clinician will go through cycles of increasing that dose to get to some point of efficacy. At some point, if it's not effective, they're going to switch to some other medication. That's their standard process. Now, it's not like an antihistamine, where if you give somebody's allergic, you give an antihistamine, it either takes effect right away or not. Something like an antidepressant and many other medications as well take time to actually have effect, and it's variable time. And so it's you get a treatment, you come in 2 weeks later, and there's a conversation around whether you're doing better or not. It's fed by largely retrospective self-report and really very little actual data on how you're doing. And finally, as that treatment process is going on, the details about how somebody is doing and what they're doing and what are other confounding factors that might play out, whether it's taking nutritional supplements or supplementing painkillers with acupuncture, if you go to your clinician, for the most part, they will appropriately answer that they don't know that there's no evidence that a nutritional supplement or some additional behavior makes any difference. And it's true that they don't know. That doesn't mean that it doesn't have effect. It just means they don't know, because there's very little data collected around those things and very little in the way of a commercial system to drive the standard evidence-producing care. So mobile health is all about trying to change how we treat, how we take care of ourselves, and how we produce evidence. So let me take this down on a level of detail. Right now, we largely create health evidence through randomized control trials, right? You take a group of people, you randomly assign them to 2 different treatments, and you see which treatment is more effective. Does it work on average? And you maybe get some result that 75% of the time, this new pharma-based medication, this new treatment plan, works better than the old standard or some other approach. A patient walks into a clinician's office. It's not the beginning of a joke. And how does the doctor know whether they belong to the 75 or 25%? Okay, so clinicians go by what has worked best in the past with their patients, but in many conditions that can be treated by a crossover design, not surgery, okay, but medications, maybe medication that somebody's going to be on for the next 5 years, you can now think of spending 2 weeks on one of those medications and 2 weeks on another, collecting data about confounding factors and how somebody's doing, and decide what's the optimal treatment for them. So there's a whole notion of, and a work around methodology of N of 1, right? The N is 1, and you start collecting data, you use that for treatment, you create more evidence, and so there's really an opportunity here to change the way we understand personal health care. So I've thrown out some examples as I've gone along. You can think about hypertension. Hypertension is even more complicated to manage in somebody who's diabetic. As I said, these comorbidity across diseases really makes things more complicated. Mental health. The World Economic Forum called out mental health separately as this additional economic burden. And if there's one area in which mobile health I think probably has the biggest opportunity for having an impact, it's in mental health, because there's not a blood pressure cuff you can put on somebody to identify depression. You can't just check their blood glucose to get an actual measure. There's a tremendous amount of both subjective and limited sources of data about how somebody is actually doing. But if you start to look at how somebody is actually doing, such as what time are they getting to work or school in the morning, and what are their sleep patterns, you start to actually bring daily functional data to the story. Similarly, I was mentioning GI problems, one in which there's a huge amount of self-management and people don't understand what causes the flare-ups. There's very little evidence around whether you think it's gluten or lactose or what have you. Again, when you go to most clinicians, they will say there is no evidence that that will make a difference. So they treat as they can with evidence based on pharma. And the question is, can people begin to build more personalized models because they're more systematically able to capture data around these conditions? So across these range of things that I've mentioned, from depression to diabetes, to high blood pressure, to GI, to chronic pain, there are many common features, and this is where we start to get to the point of the power of the information technology. That as Scott was talking about, that it's all about modularity and abstraction and reuse, we start to see opportunities for that very much so in the context of mobile health as well. It's all a combination of some smart self-report. There are some things like knowing the intensity of somebody's pain or whether they've taken their meds, that it will be a while before we're automatically detecting that. And so the ability to interact in a lightweight, possibly gamified manner with an individual, and making it really easy for people to monitor something that they're interested in monitoring, you know, with taps on the phone, not heavy-duty surveys. But even more interesting, and what I'll spend most of my time talking about, is leveraging the passive monitoring that you can do off of the device. Because the device is largely always with us, or maybe it's 70% of the time, it's actually with us and not sitting on a table. We can pull off of that data a lot of digital exhaust and a lot of information about how an individual is behaving and how they're responding and how they're doing. So, and that data capture happens because I have a mobile device on me. That's the source of the data. But all the inference that's going to be done on that data is largely happening in the context of the cloud and in the context of models that exist, and in the context of historical comparison to myself at previous times, and over time as we have more of this, as we develop better population models. Let me skip that. So where the opportunities are here, and technically where some of the challenges are, have to do with actually leveraging data that you can get from the phone to make meaningful inferences about the state of the individual. So that story I was telling you about personalized health, that feedback to self-care and that feedback to clinical care can actually happen. And let me tell you more about that. So if you're lucky enough to have an Android phone, how many of you have Android phones? Nice. So if you're lucky to have enough to have an Android phone, you can run software on your phone that is passively monitoring things in the background. This is just an example, not beautifully visualized, but I'm always running software on my Android that's monitoring, comes up every minute, spends a few seconds sampling the accelerometer, the Wi-Fi, fingerprints, GPS only when it needs to because it's power hungry, and cell tower connectivity. And it captures that data, stores it until it has connectivity, uploads it to a database, and there data is classified. Some of this can be done on the phone instead. And you basically get a continuous 24/7 trace of physical modality. Most importantly, are you sedentary or are you moving? That's the biggest difference, where driving is the equivalent to sedentary. But also information from your location trace. So yes, if you're an iPhone user, you can buy a Fitbit and sort of try to, you know, fit this together. But largely, you're from a less well-serviced population. But it's okay. So from this continuous activity trace, here's one of my favorite atypical days. I'm not bragging because my time is really bad, so this is the LA Marathon, but it produces a really nice, yellow is running, and this is all no touch, right? This can just happen with software running on your phone, basic activity classification algorithms running, and you can get these kinds of bar charts, which isn't something particularly actionable. You can start to get daily summaries, and more importantly, you can start to get trending. You can look at maps like this, but they're sort of fun for individuals to look at, but they're not particularly actionable. What you really want to be able to do is take this and turn this into some synthesized data that is really an outcome marker for an individual, right? This is raw data, but what I really want in this context of something like chronic pain, and this is from a pilot that we're just now doing, is that you can take an individual with chronic pain, let's say rheumatoid arthritis, and they're being put on a new medication. It could be part of a clinical trial. It could be some medication which you're trying to establish if it's effective for them and what the dose is. And yes, you can ask them questions like, how is your level of pain, on a daily basis instead of just when they come in that morning. Maybe they overly exerted themselves before they come in for their clinical visit. So already the phone, even through nothing automatic, can let you get more ecological momentary assessment, not just how are they feeling when they come into the office. But more importantly, you can see the fingerprint of how they're feeling and how they've been feeling through their mobility. So looking at data such as what is their cumulative number of minutes ambulatory in a day? And it's not that necessary, this isn't going to be some clean thing that's declining every day. You do activities. These are noisy sources of data. But as they're being treated, and these are not from treated individuals, this is from a technical pilot, so you don't see any of the patterns that the clinicians expect to be seeing in this pilot we're now running. Cumulative number of minutes per day is an interesting indicator that is separate from their recollection of how much they're experiencing pain. Another example is their duration of walking. So there's a standard in a lot of areas of things having to do with neuromuscular called the 6-minute walk. The way they evaluate you is you come into the office and you walk for 6 minutes around the floor of the office building, and they have little pieces of tape marked off, and they see how far did you walk in 6 minutes. That is the defined medical standards. That's in the guidelines. A 6-minute walk on a flat surface around the medical building when you come in for a clinical visit. But we don't have to have them come in for a clinical visit, right? You can be opportunistically capturing 6 minutes, and you know from map and information, are they walking uphill or not? And you can get a much more regular ecological in situ measure of what are the walking distances and walking speeds of an individual in their natural environment. Is it always on them? Is it on them every time they walk? No. But now you're able to pull from a sample that's across the full week or 2 weeks in between when you would otherwise be seeing them. Another very relevant measure to these chronic pain physicians is time spent at home, and even more importantly, what time do people leave the house in the morning? The time between when somebody wakes up and when they leave the house in the morning. For a rheumatoid arthritis patient who started on a new medication, it's that measure of is it actually reducing their morning stiffness, which causes them to be slow to get out of the house. That's the clinical measure that now you don't have to ask subjectively and retrospectively. You can actually have precise measures of. It turns out this is the same, this is a very relevant number for people who deal with depression. This is a relevant number for people who deal with ADHD in young adults. It's a relevant measure for people who deal with GI problems. When does somebody feel comfortable and safe leaving the house in the morning? So all available now quantitatively at the right kind of resolution to feed those feedback loops. And so what's behind this is sort of similar, I would say probably much less complex, but similar to the process that the community went through with respect to speech and vision, which is now developing these lower level modular classification approaches that you can pull out of these data streams, starting to build them up into higher level semantics. So you can find lots of different algorithms and classification algorithms, and you can build fancier and fancier ones that do get better for getting more and more accurate inference of sedentary, ambulatory, and such. and then you build those up into higher level semantic features like these minutes, sleep times, time spent before leaving the house, the diameter of your day. And as you go up to particular diseases then, these are going to turn into particular outcome markers dependent on the particular condition that you're looking at, whether it's fatigue, pain, depression, cognitive function. And the real focus for the work is in using it for looking at in-person variants. So not suggesting that at this time you're going to do something diagnostic to notice from somebody's records that they have a particular condition, but initially very powerful in helping it to serve their personal feedback loop of drug titration and treatment choice. And a lot that can be done on today's mobile phones and will be leveraged from off-board devices as well. And then something that's an area where people are starting to work in a similar mode is to move on from just physical patterns of location and activity to things like communication patterns through the mobile, texting communication. Tanzim Chowdhury from Cornell has some very nice work sampling speech patterns. So taking somebody's speech tone opportunistically when they're on the phone as an indicator of stress level. For example, in bipolar, it's an indicator also sometimes of manic phases. So many opportunities to leverage the ways in which our people mediate their lives on their phone by doing this same sort of pulling out of lower level features and building it into something that's a relevant marker. And as I sort of led into this, how it then can be used is to drive those feedback loops for the patient, for the clinician, whether it's about informing that initial treatment optimization or with occasional sampling periods detecting relapse, and as I mentioned, and importantly, generating clinical research evidence, and really across a wide variety of conditions. Let me take a moment for a tangent. This is such an embarrassing story that I decided the only way I could deal with it is if I told it in public. I don't know if you have this expression here about eating your own dog food. I don't even know where that started, but that's what experimental software folks do. And so as I said, I always run these activity classification algorithms, and so this one user was experiencing, this happened like last month, I was experiencing these intermittent, unpredictable, completely uncorrelated errors from my accelerometer reading. And it went on and on and on, and nobody else in the group or any of our pilots was having this problem. And I was having all those, you know, that nice little barcode I showed you, there were all these gray, meaning error, you know, lack of data periods, and I kept seeing errors on my device. And we could not we couldn't, the grad students and the staff couldn't tell me what the problem was. And so we finally sat down to stare at the data and to stare at some logs. You know, was it faulty phone hardware? I tried switching my phones. We upgraded the OS. We looked at interplay. And of course, they accused me of being overly hyperactive. And so I was, you know, causing the accelerometer to go out of range, all this silliness. Well, there was this one undergrad sitting at the meeting, who's in our group. And I look, and he's looking on his laptop at a spec sheet that says draft on it. And he looked up the error code that came up on the accelerometer. And it said something about accelerometer range out of bounds. And a little while down further, it said something about magnets. So he says to me, "Are you around magnets?" No, I'm not around magnets, and completely dismissed him and went on with the conversation. 20 minutes go by, and we're sort of about to give up. Clearly, the problem isn't going to be solved. And he came back. He's very, very smart and very sweet. He said, "Are you sure you don't have a magnet in your purse?" So I'm a product of the 70s, and I want you to know I don't carry a purse, okay? I have a pouch for my phone. And so I almost said no just because I so wanted to reject the notion that I had a magnet, let alone that I had a purse. And I won't swear, I won't repeat what I said inappropriately in front of this group of students, but I just sort of put my head in my hands, and yes, I had magnetic clasps on my pouch. And these were really, really strong magnets, sort of rare earth magnets. There were actually 4 of them. We did sort of surgery on it. And it was embarrassing because, you know, I do have an undergraduate degree in electrical engineering, accelerometers, magnets. Anyway, I decided it was such a horribly ditzy story that I had to tell the story about myself instead of people telling it about me. That being said, we sort of wrote up this tongue-in-cheek article about, you know, problems with diversity and access, you know, in terms of equity, gender equity, in terms of usability of mobile health because of the use of, you know, anyway. Okay. So getting to something a little bit more serious here, and much harder to solve. These traces that I'm talking about leveraging for mobile health, and that it's moving into being of greater interest across a range of clinical domains, brings with it some things that are of concern, right? They're very powerful traces, and they're very telling traces from a privacy perspective. And it's just, in some sense, and for clinicians as well, a lot of the response of clinicians is, this is way too much information. I don't know if that's sort of a phrase here, but too much information is you're giving me way too much detail for a bunch of different reasons. Physicians can be concerned about it because it's overwhelming or because it's liability. And I think from a consumer, citizen, participant perspective, there is a certain amount of information here, a certain amount of concern as well over the privacy implications of those data. And maybe this is the last opportunity to actually convince people that there is still some remaining notion of privacy. I know people like to say that, that the youth don't care about privacy. I think that actually it's a silly statement. They might have different notions of privacy and who they want to see data or not. They might share all kinds of information that we might consider intimate on social media, but they don't share it with their parents. And the young don't stay young. That's one thing we know, okay? And so the young don't stay young and without any health issues. And as you get into areas of health, there is an opportunity to perhaps change what we have set up as the norm for interaction in the context of the cloud. The norm for interaction on the cloud is that any transaction is a shared transaction with a vendor. You go to Amazon and you buy something, the data is yours and the data is theirs. You go to Google and you search, it's your data and their data. You go to Facebook, it's your data and their data. And that has produced very powerful markets for personalization and all of that. And, you know, kol hakavod. But in the context of health, maybe there is an opportunity to say, wait a minute, just because I capture some information doesn't mean automatically that all that raw data belongs to anybody else. That there is a notion and an important context in which data should be able to be truly private to me, and that I selectively share from that features. So think back again. I talked about this raw data out of which you extract features. The raw data isn't relevant to my clinician. The extracted features are. The raw data doesn't have to be relevant to my commercial service provider or my employer or my insurer, but the features might well be relevant to them. And so the whole notion of starting to build and have an opportunity to have personal data vaults in which our data is truly private in the cloud, encrypted containers in the cloud. This is not so much a strictly technical problem, and that from a security perspective or a crypto perspective, I think there are a lot of existing techniques we can use, but it is the same problem that increasingly people discover in other aspects of privacy, which is that has to do with usability. And how do you actually produce policies that people can actually use? And I think it all goes all the way down from a challenges perspective to the legal and the business models. The business models clearly, since so much of what has come about in terms of free service has set a norm of this shared ownership of data. But legal perspective also, I don't know the laws here in the US, your diary can be subpoenaed. So if your diary can be subpoenaed, these private logs can also be subpoenaed. You can't plead as we say in the US, you can't plead the fifth and say you don't want to incriminate yourself. Your diary, you're not incriminating yourself, but your diary can incriminate you. Therefore, these logs can as well. Nevertheless, the notion that somebody has to come and subpoena me for my private information has a different barrier than that they have to go to my service provider and they can subpoena a whole bunch of records from a service provider. So lots of issues here that are both technical, usability-oriented, and legal. And there's some good work that's happening in a number of places starting to look at this question of, can we move and shift some of the way in which personal data is captured and shared in the context of social media as well as health services. So I just want to end and come around and relate a little bit to the excellent talk that Scott gave before the break and say that progress here, and I would say progress in bringing information technologies to evolve the state of healthcare, really needs to go back to those those core elements of what is the power of computing. It's about abstractions that allow modularity. And in the context of mobile health, the reason we started this effort called Open mHealth is in fact to try to bring some of the notions of architecture and modularity and shared use and even, God forbid, open source components in order to create really healthy, effective ecosystem in this space. When I'm in Washington, D.C. and around NIH and a lot of health people, I've come to start explaining to them that open source is not socialism. And the first time I said it as a joke, and I looked at the person and I realized, oh my God, I was informing them of something. And fortunately, but I'm just this, academic. There was a guy there from Google standing next to me who quickly came in and said, yes, it's really a cornerstone of most of the, healthy web and cloud ecosystem. And we really need to do that here as well. And so in the context of Open mHealth, we're trying to build a community and reference implementations and such that try to bring that kind of modularity and abstraction to this space so that across these different conditions, all of that sense-making that needs to happen around these data streams and opportunities for having things like personal evidence architecture can occur at the rate of our information technologies and not occur at the rate of our health information technologies, which have been, I would say, the state of progress in standard electronic health records and such has been a real example of market failure here. So to end, I sort of want to come up another meta level, another level if I can, and make reference to my thesis advisor, Jerry Saltzer, and some of our colleagues from early internet days, who at that time wrote a paper that's now sort of a standard reference to, this is an end-to-end argument, okay? Or the end-to-end argument would say X. And that had to do with an argument for where you place functionality in a system. And where this work came for me is from, and where the last sort of 10 years of having a center around environmental monitoring really came from the notion that it's really important for the systems community to actually have authentic applications in the process of doing experimental systems research. That the end-to-end argument really goes so far as to apply that we need authentic application drivers and we really need co-innovation across the technology and the application domain, because we need the application domain itself to start to think about architecture and modularity. That the methods that are used in health need to not just be monolithic treatment plans, but start to be things that have modularity that can be mixed and matched and combined so that these fields, whether it's sustainability or healthcare or entertainment, can experience the kind of rapid evolution that we've experienced in the internet. So finally, just to close, the phone is not the perfect device. There's this expression from many years ago from Rumsfeld at the time. He made this comment about if you can't go to the field with the army you want, go with the army you have, which offended many people. But a play on this: if you can't just get 6 billion new perfect sensors out to people, but you can leverage what they actually have in their pocket and what they spend discretionary income on, and that's really made powerful by the fact that you have the internet-based cloud behind them. Lots of issues having to do with usability and privacy and things to really make it work. And increasingly, and I was happy to hear sort of more attention to that in some of the introductory remarks, we really need a healthy research ecosystem where you have applications and system building and theory together co-innovating. And finally, just some of my favorite recent reads. Thank you.